ventroposterior medial thalamus, and pain modulation system like hypothalamus and basal region. Uh, Roughly, there are two, three types of presentation, be it primary or secondary. Either a chronic daily headache, which can be classified into less than 4 hours or more than 4 hours, a medication related or medication overuse headache, a sub entity called new daily persistent headache, or acute headache. The causes of acute headache versus chronic daily headache are very, very different. And always remember, in case of acute headache, red flag signs are to be noted. So, to begin with the topic of migraine, I welcome Dr. B.K. Tripathi, consultant and professor, ex HOD at Safdarjung Hospital. Thank you, sir, for joining.
Thank you, Dr. Bharwa, for giving me an opportunity to speak in front of this elite gathering of CGHS doctors. The topic, as you have just introduced, is the migraine. In fact, the difficulties in diagnosis is forefront of this clinical entity because it does not have any proper definite clinical spectrum or any marker or any investigations which can support the diagnosis and you can successfully treat the patient. But still, we'll go through the whatever is possible regarding the diagnosis and treatment of migraine. I remember my old days when I was doing my MD, and my professor used to tell that whenever a patient of headache walks into your clinic and he tells that I have been having headache for last 6 months, 1 year, or 3 years, probably this gives headache to the doctor who is sitting across the table rather than patient himself, because I understand that the diagnosis and treatment is very, very difficult, and this is why I've chosen this topic to discuss things in front of you. Migraine, as far as definition is concerned, it derived from a Greek word that means hemikranios, that means half headache, pain involving half the head. And as you'll go through that, you'll see that this is a very cardinal feature of migraine, that the pain in head is localized mainly to the half of the head. It affects number of people, 12% of population. What a sizable number you can see. And it is commoner in female gender, almost 3 times commoner as compared to men, 18% versus 6%. Chronic migraine, which I will be talking just now, will involve nearly 1 to 2% of global population. Now you can estimate, you can calculate that how many people are involved, are suffering from chronic migraine. They're definitely a very a big cause of disability. This is again the same thing, but I have just said that you can see that the red orange the graph is showing women. They are almost 3 times higher. The incidence and prevalence is 3 times higher than men. And you can see the commonest age group where it is hitting, it is the maximum, is around 35 to 40 years. So by and large, this is a disease of young people, whether it is men or women. As I told just now, that it is difficult to diagnose because many times the entity, clinical entity, is diagnosed as the patient is giving the history. Sometimes patient may not be that intelligent who can narrate his problems successfully, and then definitely the diagnosis will be difficult. There is no diagnostic test. There is no you. The moment a patient will come headache and he will himself dictate you, डॉक्टर साहब मेरा एक MRI करा दीजिए, मेरी CT scan करा दीजिए. But you know that CT scan and MRI will never be able to clinch the diagnosis of migraine because there is no structural or physiological abnormality seen in MRI and CT. And another problem that there are a number of symptoms like giddiness, nausea, vomiting, some neurological deficits, which overlap with the diagnosis of migraine. So many times on one side it is migraine, on the other side it is some organic illness like CVA, stroke. Many times it is misdiagnosed as CBA, TIA, seizures. I'll be talking in more detail with these diagnosis, and you will see that how difficult it is to make a diagnosis of migraine. Basically, it's a diagnosis of exclusion, and definitely I'll advise you that the moment a patient comes to you with history of headache, do not jump into the diagnosis of migraine, because by and large, in the list of DD of headaches, migraine comes in the bottom of the list. And more important, more significant, more disabling diagnosis should always be considered at the first instance. These are the phases of migraine that in some books describe it as only three: aura, headache phase, and postdrome. While a prodrome phase has also been added recently, and this also carries its own importance. The prodrome is 1 to 2 hours prior to the development of headache. It is characterized by yawning, tiredness, cognitive dysfunction, mood changes, less discomfort, polyuria, and food cravings. So many times they are such a blunt and insignificant complaints that patients may not even notice them. But if they are occurring repeatedly, then intelligent patient definitely will come to know, will immediately interpret probably that he's going to have an attack of migraine. Then the second phase is aura. Aura is more informative. It is seen, unfortunately, is only 33% of patients. It is both negative and positive phases. It carries what exactly is negative and positive. I was just talking, but fortunately, it is completely reversible, and then it gives way to headache phase. So once the patient lands into the headache phase, then probably in retrospect manner he will realize that he about just about half an hour or 1 hour before he was having aura. So the headache phase is, of course, headache is there. Then nausea, vomiting, photophobia, phonophobia, allodynia, and olfactory hypersensitivity. Allodynia means the over sensitization of pain. Uh, So it is like that. Then once the pain, the headache passes off, then patient goes into the fourth and the last phase, that is post-drome, that is feeling tired, problem concentrating is difficult, he is difficult to solve, answer questions relevantly, and some mild discomfort. Aura a little bit more in detail. Aura can be related to many special senses or regular senses, that is visual, flashing lights. As this video here is showing, these are the lights which the patient will encounter. Auditory means tinnitus, noise, and music. Even if there is no music being played in the room, patient may listen to music. Somatosensory, then burning pain, paresthesia. Motor, again, very important, and which may be very obvious, always noticed by a patient or his attendant. Jerky or repeated rhythmic movements. And sometimes language, patient will not be able to speak relevantly, or he may be having frank dysphagia. Loss of vision, like this is what exactly I just told you, that there are certain negative symptoms which patient may encounter in aura, that is loss of vision, transient loss of vision, transient loss of hearing, feeling, and ability to move part of the body. In fact, ability to move part of the body is not paralysis. It is only the part of aura which the patient recovers immediately soon after that. There are certain triggering factors as well, which definitely we should know and we should thoroughly investigate and inquire about once the patient is coming with suspected diagnosis of migraine, and that is glare, bright light. Many times you have encountered the patient will come कि कभी भी जब हम धूप में बाहर जाते हैं, then I get this headache and this is why I am afraid of going, or I am definitely bound to take those prophylactic pills just to avoid an attack of migraine. Hunger, patients should not stay hungry. Many times you have encountered these the middle-aged housewives, they will give you history. डॉक्टर साहब सुबह उठ के हम हमारे घर का बहुत काम होता है, और पहले तो सब बच्चों बच्चों को अस्पताल वो स्कूल में भेजते हैं, फिर खाना वाना पे बनाते हैं और फिर पूजा करते हैं। 12 बजे से पहले तो हम चाय या नाश्ता ले ही नहीं पाते हैं। So always think of it that hunger may precipitate an attack of migraine. So always advise your patient to not to stay hungry. Emotional stress, very, very important. It's very easy to tell your patient that you should avoid stress, but it is very difficult to observe it. Physical exertion, if patient has extra load, some guests have arrived and the patient is putting lots of work in the household, then again it may precipitate an attack of migraine. Hormonal fluctuations, very often seen related to menses. Many patients will come with history, and it is always good to inquire this history whether you get the attack of migraine during your periods. Sleep disturbances, if the patient is not being able to sleep because of stress or physical strain, then alcohol and nitrates, all these medicines can also act like a triggering factor. Now, I told you in the beginning that only one third patients will be able to recognize this aura. Nearly two-thirds of patients, that means 67% of patients, may not have any aura at all. Then it is again very, very difficult to diagnose migraine. But this is the table which I have brought to you. And if you pay attention to this table, you'll probably will be able to recognize patients of migraine who do not encounter ARA. A, B, C, D, E, there are five parts, and A is at least five attacks fulfilling criteria in B to D. Just pay attention to these B, C, D. And the definition is saying that headache lasts for 4 to 72 hours. This is one criteria. Then headache has at least two of the following four characteristics. You have to inquire the history of the patient and very meticulously. Unilateral in location, very, very important. Pulsating quality, moderate or severe pain, intensity, then aggravated by movement. All these four the complaints are very important. You have to inquire it very thoroughly. And if two of them are present, then probably it qualifies for one criterion of diagnosis of migraine. Then coming to D, the headache will be related to one of the following, that is nausea and vomiting. Many times patient along with headache feels nausea and he vomits once or twice. Nausea and vomiting again is very, very important, but because when we will be talking about the treatment, then we will realize that vomiting does not allow the proper medication of migraine to act, because the moment patient takes a pill, he vomits it out, and then it is not allowed to work or act. Then photophobia and phonophobia. These is again very important. So at least one of these, then two of those criteria in C, and headache lasting for 4 to 72 days. So B to D will definitely, if you write it down and you will start ticking, then probably it is very easy to do the diagnose criteria. I have probably made a mnemonic for recognizing, that is pound, that is pulsating or throbbing pain. Characteristic feature of migraine: 1 day average duration, unilateral location. Unilateral location is very, very important, because tension type of headache, which is another type of headache, will always be bilateral. So if you are encountering a unilateral location, unilateral headache, then probably it is favoring the diagnosis of migraine. Nausea and vomiting and disabling type of, very disabling type of uh, headache. Then migraine with aura. I have just talked about what exactly is aura. At least two attacks fulfilling criteria B and C. Here, what type of aura? It can be visual, it can be sensory, speech or language, motor, brainstem, retinal. We have already talked. Retinal is probably you start feeling there's some blurring of vision or some scotoma or something like that. So this is, of course, it is very rare and many times patient will not be able to recognize. But you should keep this thing in your mind, because this is one of the type of aura which patient may encounter. Then second is at least three of the following six characteristics, at least one aura symptom spreading at more than 5 minutes. Two or more aura symptoms in sequence. Each individual aura symptom lasts for 5 to 60 minutes. Please remember, not less than 5 minutes. If the symptoms are lasting less than 5 minutes, probably it is not aura, it is something else. At least one aura symptom is unilateral. At least one aura symptom is positive. no negative. If you see that all the aura symptoms what the patient is telling you are negative, that means loss of vision, loss of hearing. These are some negative aura symptoms, but or not all aura symptoms should be negative. There has to be some positive symptoms. The aura is accompanied by at least 60 minutes by headache. Well, the aura means the patient should have headache within a matter of 65 minutes. Again, very important, of course, not that common. The brain bacillar type of migraine, then migraine with brain stemora. It is very difficult. I know it's very, very difficult to recognize and connect this aura symptom with the migraine, because whatever symptoms I have enumerated here is dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, and decreased level of consciousness. All these symptoms, you know that these are the functions of brain stem in your body, but for a patient it is difficult to connect this with the onset of pain, or he may be always ignoring it. Then a one condition that is called hemiplegic migraine. This is a very typical question of our MD examination, that tell me the causes of reversible hemiplegia. You all know that hemiplegia is the disease of uh, major arteries of your brain, cerebral cortex, that is middle cerebral artery or anterior cerebral artery, but they are not reversible by and large. So if you encounter a case of reversible hemiplegia, that means patient developed hemiplegia, weakness on one side of the body, and he recovers in a matter of 1 2 hours, then probably you are encountering a case of hemiplegia, hemiplegic migraine. Plus, please remember the hemiplegic migraine is not the only one which will give rise to reversible hemiplegia. There are other things like TIA or RIND, reversible in intracerebral neurological deficit. They are all the causes of reversible hemiplegia. But of course, hemiplegic migraine is definitely very one important diagnosis which you should keep into your mind when the patient will come with the history of he was not being able to move his left side of the body, but by the time I arrived to you, I came to the hospital. Now I completely recovered. So this is reversible hemiplegia, and this entity is known as hemiplegic migraine. Chronic migraine, as Dr. Bhargava has just mentioned, or chronic migraine, again, very, very important entity, and this is slightly different with acute onset migraine. The definition wise, it has to be at least 50 headache lasting at least 15 days in a month. Remember, headache, it is not migraine. Headache lasting more than 15 days in a month for 3 months together. And out of these 15 days, at least 8 days a month, the definition of headache should fit with the diagnosis of migraine, which we have just talked about. Diagnosis of migraine, uh, these are some important points which we would like to discuss. High index of suspicion is essential, because if the young lady around 35, 40 years is coming to you with long history, probably history of headache for last 1 to 1.5 years, and he develops headache at least once or twice in a month, then probably it is fitting, STY, it is fitting with the diagnosis uh, with migraine. It is a clinical task based on the compatible history, physical examination, diagnostic criteria. So, if the patient is giving such type of history, you should go for a certain examination, physical examination, and diagnostic criteria, which we have just discussed. Any patient with episodic headache with normal physical examination, think of migraine. Please think of migraine. Episodic headache of long duration, 6 to 12 months, with normal physical exam. Think of migraine as a first different diagnosis. Can be anything else also, but migraine should come in the list, top in the list. It should be, of course, there should be differentiated with another primary causes. Secondary causes of a headache, which we'll be discussing right now, should also be taken care of, and should be we should pay full attention to the causes of secondary giving rise to headache, and we will be just talking about, and red flag signs, again, very, very important for excluding the possibility of an organic illness. These are the red flag signs. These are important. Why? Because if one of these are present, do not think migraine because they probably they are hinting at the other diagnosis. What are they? Sudden onset, thunderclap. That patient was perfectly okay. He got up in the morning perfectly okay. He took cup of tea and in a matter of 5 or 10 minutes, he developed headache, thunderclap headache. First or worst, first headache, and that was the worst headache, again, is not hinting at the diagnosis of migraine because it gradually develops. Today it is headache, then after 7 days, after 2 weeks, again the patient develops headache with a bigger intensity. But first headache, if it is very, very severe, then it is not probably you are dealing with a case of migraine. Recent significant change in the pattern. Patient has been having headache for last 8 or 10 years. Probably it was fitting with the diagnosis of migraine, but suddenly in last 2 or 3 months, the patient started having severe excruciating headache along with some other symptoms. Think of that probably you are encountering with another diagnosis in the background of migraine. So don't ignore it. Headache with neurological symptoms. I will be talking about just once again. Abnormal examination finding that the patient is coming history with 3 months history of headache and he is having probably monoplegia or some numbness or tingling. Then headache associated with syncope or seizures. Again, scissors probably is not, syncope is not a feature of migraine, as you have seen in the past, that we have not enumerated these scissors and syncope as a feature or as a symptom of migraine. New onset headache, especially after 50 years. I told you the common age group is 35 to 40 years, but if the patient has been okay for the last 50 years and suddenly he starts developing uh, headache, of course, periodic headache, then probably the migraine diagnosis should not come into your mind as a first. New onset headache, associated symptoms and signs such as fever, stiff neck, papilledema, all these things are very, very important. Please remember, these are some certain symptoms and signs which are hinting against the diagnosis of migraine. Because migraine does not probably has lots of physical signs, but in all these clinical situations, like stiff neck hints at the meningitis, papilledema hints at the space occupying lesion, cognitive impairment, and again probably stroke and personality changes are again probably you are dealing with a case of dementia. So I have again put this mnemonic here, that is Snoop. Remember this mnemonic Snoop, SNOOP, that is systemic sign and disorders, neurologic deficit, onset first or worse, onset thunderclap, papilledema, pulsatile pain, tinnitus, positional changes precipitated by exercise. All these symptoms definitely are really speaking against the diagnosis of migraine. So remember that this is not migraine, and Snoop is probably a mnemonic which we'll remember always. This is the diagram which is showing that certain secondary headache which Dr. Bhargava has just talked about. There are certain intracranial or extracranial conditions, pathologies which will give rise to headache. They are grouped under the heading of secondary headache, that is meningitis, sinusitis, glaucoma, cervicoarterial dissection. Again, very, very important, does not have much of clinical signs and symptoms. Temporal arteritis and cervicogenic pain. I have divided these features of secondary headache in tabular form. CVA is again very, very important, and all these things are available and are the same. We can see which probably support the diagnosis, contribute to the diagnosis. CVA, that is TIA. Many times you remember the CVA diagnosis is always preceded by certain symptoms which suggest TIA. And when the patient develops CVA, it is in the same territory which probably he was experiencing TIA in last 1 or 2 months, and probably he was ignoring it. Then cerebral infarction, intracranial hemorrhage, AV malformation, arterial dissection, and venous thrombosis and vasculitis. These are all the significant diagnoses supporting the diagnosis of cerebral vascular disorder, CVA, non-vascular intracranial disorder like benign intracranial hypertension, of course, a rare disease. But if you do not find anything significant in the cause of headache, then you can think of and you can investigate the patient for this clinical entity. Low CSF pressure again give rise to headache. Intracranial neoplasm is very, very important. Initially, many times it presents like headache. And then certain drugs will give rise to regular headache, that is nitrites. We all know that when earlier we used to prescribe nitrates for ischemic heart disease, and patient will always complain of nitrites, and we can console with whatever words, and nothing can be significantly done for such type of nitrate induced headache. Many time patient develops tolerance to nitrates induced headache, and we continue with nitrates. Then hypoxia, hypercarbia, that means high carbon dioxide level in blood, and of course hypoglycemia. They all are causes of secondary headache. Then cranium, neck, eyes and nose, cervical spine, sinusitis, glaucoma is a very, very important. And many times physicians, general practitioners and neurologists do not think about glaucoma at the first instance. Only if they do not find anything significant, they refer the patient to the eye specialist. Refractory error, of course, patient may need use of power glasses. Arnold Chiari and malformation, a rare AV malformation inside the cranium can give rise to pain. And epilepsy, trauma, and meningitis. These are some. Of course, epilepsy is not an important cause of headache. I'll be talking just about the difference between migraine and epilepsy, and then you will realize that my epilepsy is not an important cause of headache. Yeah, it is here. Migraine with aura versus seizures. Many times, what happens, the patient may not be that wise enough, intelligent enough who can give you proper history. Then you have to find out whether you are dealing with a case of migraine or it is probably epilepsy or seizures. So these are the important differentiating feature in migraine. The aura or talkativeness. Of course, aura can be seen in seizures also, but the symptoms are different. The aura which is seen in migraine, that is talkativeness, appetite changes, sleep disturbances, numbness and tingling in the extremities and faces, and pre-aura prodrome is more common. While on the other side, scissors aura is feeling of heaviness, depression, and patient probably will have a hint that he or she is going to have an attack of scissors. Probably is a premonition for him. So this is included into part aura of scissors. Following a scissor, the man, the scissors occur and post-ictal headache is brief. Of course, post-ictal headache is very common in cases of epilepsy or scissors, but not pre-ictal. Pre-ictal aura, of course, will be there, and after that, the patient goes into sleep, and when he gets up after 5 or 6 hours, then he is having an attack of headache. So don't confuse that it was an attack of migraine. And investigations, of course, we go for EEG, electroencephalogram. Uh, then probably you will be able to pick up the diagnosis of epilepsy. Just pay attention to the lot. This box written in the bottom. Migraine triggered seizures are common. That means even if the patient is having migraine, the diagnosis is correct for last 2 3 years, and he is being treated for migraine, he may develop epilepsy, the problem, which is a commoner entity. It is co-occurring with migraine. So always remember, do not just exclude it out that, oh, it's a case of, it's an attack of my epilepsy and it's not probably, it was a misdiagnosis of migraine. So both the clinical entities can occur together. Then coming to the migrainous infarction, all these things are relatively rare, but definitely just to keep things, everything in your mind. I am brought this thing. This is migraine with aura. It is migrainous infarction, as if you are dealing with a case of CVA, which is preceded by migraine. So migraine giving rise to stroke or paralysis is called migrainous infarction. And many times it is seen in my patients who migraine with aura, with one or more the aura symptoms. And the neuroimaging, surprisingly, as I told you in the beginning, there is no investigation by which you can pick up the diagnosis of migraine. But here, if the patient develops infarction, if the patient develops neurological deficit, hemiplegia, monoplegia, whatever it is, then probably if you do the MRI or CT scan, you will pick up the diagnosis of ischemic infarction. And the exact reason is not known, but it is called that vasospasm of the major artery, changes in cerebral blood flow, and neuronal hyperexcitability. These are certain causes by which you can say that migrainous infarction can also occur, though despite it is very very rare. What are these important risk factors for ischemic stroke? Migrainous aura in women younger than 45 years of age, late onset migrainous aura, and active migraine with increased attack frequency. If the person is having the migrainous attack very common, say about 2-3 times in a week, then all these things are predisposing the patient to migraines function. Of course, it is very, very rare. Now, what is the left for the examination? It's very, very unrewarding, I must say. If you examine your patients with pure migraine, temperature will be normal, BP will be normal, there will not be any neurological deficit, anemia signs will be absent. And if you palpate, then sinuses, of course, will be normal because you are not encountering a case of sinusitis. Temporal artery will not be palpable because you are not encountering a case of temporal arteritis, which is a common cause of excess type of headache. Pericranial muscle tenderness or muscle spasm will also be not be very very rewarding. Examination of eye, of course, if there is causes for headache for secondary like papilledema and all, then definitely you can see. But as far as migraine diagnosis is concerned, examination of eye, even the fundoscopy will be normal. Cervical spine and everything will be normal. You will not be able to hear a plea, which is a common feature of patients of CVA or the patient who is having TIA or likely to develop CVA later in future. So the examination part is very, very unrewarding as far as pure migraine patient is concerned. Now coming to the last part of treatment, treatment is many times it is very rewarding if you can successfully delete, you can successfully exclude out the possible cause of secondary headache, and you can make a successful diagnosis of migraine. So this is for treatment of acute attack of migraine. The commonest drug what we use is naproxen, ibuprofen, diclofenac, paracetamol, aspirin, caffeine, whatever drug which is available to your formulary, and you have faith, you can prescribe. Normally we start with paracetamol, acetaminophen, and naproxen has definitely attracted lots of attention of doctors because it is many times very very effective, probably more effective than rest of the drugs which are enumerated here. Then another group that is serotonin receptor 1B, 1D agonist, and sumatriptan is on top of the list. It is basically these days the gold standard of uh, migraine treatment, because if you are treating with proper doses and proper advice, and the patient is not responding to any of these triptan, that is sumatriptan, liratriptan, rizatriptan, zolmitriptan, probably you are not dealing with a case of migraine. And this is the oral, and this is why I want to take a little the beginning when I told you that nausea and vomiting is a common feature of migraine. If you are given oral medication like in form of triptan in the paper, vomiting, when the body is not being able to absorb these drugs, so they will not be effective. So for such problem, you have some nasal preparation, nasal inhalers, nasal drops, and some parenteral also, like dihydroergotamine and suminat is available. Sumatriptan is available in parenteral form. Dihydroergotamine is also available in parenteral form. So if the patient is not being able to accept it or to digest oral medication, then you have to go for nasal route or parenteral route. Then a new drug, which is probably is not available, likely to be available in India in the near future, that is Deton. Of course, it is also hitting, it is also an agonist of serotonin receptor, but it is probably have picked up another 5-HT receptor, that is 1F, and probably it is more effective. Dopamine is a dopamine receptor agonist like metoclopramide. These two drugs, prochlorperazine, that is Stemetel, and Perinom, they should always be given along with tripton, because they will reduce the chances of vomiting the important drug the patient, and they can also be used parenterally also. Then these are the drugs, Japan, Arbogin. These are experiment drugs, so I'll not be discussing much about them. Then magnetic stimulation and some physical maneuvers are also being tried and being experimented out, and we will definitely hear more about them in next 4 5 years. Then certain, of course, preventive treatment in migraine, because many times patient will come with a history of my that I was having a headache, and then you will inquire how frequently you are having. They will say that once in a while, once in a month, once in for a fortnight. Then probably you cannot prescribe all those drugs which I have just enumerated, just discussed about acute onset migraine. Then these are the drugs which you can use for prophylaxis, and propranolol or beta blocker that comes in the first of the list. They are safe and devoid of any side effects. So you can always prescribe propranolol 40 milligram a day, especially sustained release form like Ciplar LA or beta cap TA in 40 milligram. You can up titrate up to 80 milligram or 160 milligram even if the patient is responding. Then antidepressants, because I told you in the beginning that stress and anxiety is also a consistent feature of migraine. So if you are being able to diagnose that patient's migraine may be related to stress or some depression, you can give some antidepressants. Then anticonvulsants, some specific in anticonvulsants, not all anticonvulsants, but these are two important anticonvulsants which have some anti-migraine prophylactic activity, that is topiramate and valproate. Uh, all these biologics have also been tried. Nowadays you must have heard so many biologics being tried for every sort of medicine, sorry, every sort of diseases. Here also biologics have shown some success in the prophylaxis of migraine. Other drugs like flunarizine, camisartan, metoline, they have been in use for last 20 25 years, but not very successful. They act in some patients when you have to pick and choose your patient according to his own response. Neuromodulation, chronic migraine. Then chronic migraine is very, very difficult to treat, and on a botulinum toxin. Botulinum is a basically is a gram-negative bacteria, and we extract one type of toxin, that is type A, and that is found to be successful in treatment of chronic migraine. So the take-home message, probably this is my last slide. Take-home message is that if you are dealing with the case of headache, think of red flag signs, which we'll be talking, I suppose. No. Red flag signs we have already talked about in our previous slides. So if the red flag signs you could identify, then don't think of migraine, think of secondary causes. But if they are absent, then criteria for migraine, if the patient's symptoms are fitting in criteria for migraine, think of migraine and treat for migraine. Most of the time, the patient will respond to this treatment. If the patient does not respond to the treatment of migraine, then think of some other disorders like primary disorders like band like. This comes into the DD of headache, that band like, that is tension type headache, TTH, that is tension type headache. It will be bilateral and the patient will having excruciating pain as if the band is tied around his head. Then trigeminal autoimmune neuropathy, autonomic features, trigeminal headache. Think of this diagnosis, and others like hypnic and NDPH. All these are really rare diagnoses, but these should come into your mind when the patient fails the treatment of migraine, because many times the patient responds to tripton if the initial diagnosis is correct. So this was all I have to tell you. Thank you for your patient hearing, and I'll be very happy if you have any question to respond it. Dr. Bhargava, over to you.
Thank you, sir. Thank you so much for a wonderful presentation, which was complete in both clinical and evidence-based aspects. There is a question in the chat box about trigger points of migraine and how to differentiate it with migraine and management differences in case of trigger points.
Recall point, I mean, think you can only advise. It is the part, it is the the domain of the patient. Whatever trigger point we have talked about, you see that it is you need the cooperation of the patient. That he should not be allowed to stay hungry. Stress, of course, he should avoid. Then the sleep, he should have full sleep. Overexertion is definitely all has to be avoided. So probably you will have to ask the cooperation of the patient. There's hardly you can do anything for avoiding these trigger points.
All right, sir. I have a question, sir. Sir, many times the patient with diagnosed migraine have extensive history of medication use and sometimes even overuse. So medication overuse headache sometimes complicates migraine. So how do you approach that case?
That's a very, very relevant and pertinent question. Thank you for asking this question. Uh, there are two separate entities, as you yourself described. Migraine is a separate thing, but certain drugs. Frankly speaking, I may tell you that I told you about the certain drugs causing headache, like nitrates, nitrites, alcohol, and all. But there are a number of other drugs. It is a very, very exhaustive list. And once you suspect that this drug may have caused headache in this case, then you will have to go to the literature and find out whether this really drug really causes headache. And many times you find that, of course, you are dealing with a case of headache caused by a particular drug which patient has been taking. So the migraine of if patient can avoid that drug, then definitely you can advise, and you better avoid, or you can substitute it with another drug with the same effect, or migraine can be successfully then treated with all those drugs. But if patient cannot avoid that drug, then it's very difficult situation. I mean, as I told you that in fact, 20 years before, for every ischemic heart patient, we have been using nitrates and nitrites, and almost 70 to 80% initially would develop uh, headache. But now we hardly use any nitrate or mine because there are other more powerful, successful medicines for treating ischemic heart disease. So that way, the physicians are very, very lucky that they do not have to cause some iatrogenic headache in their patients. But of course, I thoroughly understand that there are certain drugs which cannot be avoided altogether, and then probably patient will develop some tolerance if he'll continue taking that drug for next 3 to 6 months.
All right, sir. Sir, there is a entity called new daily persistent headache. Uh,
You,
New daily persistent headache in this
yes.
particular slide. How do we differentiate it from chronic migraine, say for example?
Chronic migraines probably is little history of say about months and years, not very short. While new daily persistent headache will be slightly shorter, and many times it is associated with some gastrointestinal symptoms and especially the lower GI symptoms. So by that you can of course differentiate new daily persistent headache.
Uh, all right. There is another question in the chat box. What should be the first drug of choice and the tapering dose? I cannot make
Yes,
out
of
it.
course, tapering is very, very important because you cannot continue treat patient with these or drugs because they themselves have their own side effects. The first, if the patient comes with the history, say about once in a fortnight, once in a month, then there is no point in giving the treatment for acute onset migraine. It is better you treat with certain drugs, as mentioned here for prevention and prophylaxis, and especially the beta blockers are on the top of the list. If the patient is still develops one two attacks in a month, then you can always advise that you can take this and different types of triptans, along with some drugs which will reduce chances of vomiting, like perinom or stemitil. It will definitely help patients absorb that migraine drug, and patient will be good. And as far as the curtailing and tapering of the dose, definitely you will have to continue, and you have to ask the patient to prepare a migraine diary. In fact, I have purposely not mentioned here because in India we do not advise our patient. Western literature, it is clearly mentioned the patient should be encouraged to maintain a migraine diary, and if the attacks are less than once in 3 months or once in 6 months, then you can do without these drugs. Because there's always an option of restarting the drug, but unnecessarily giving these drugs is not important. So migraine diary, you can always look once the patient is coming after 6 months, and you can see that if having any attack of migraine last 3 to 6 months, you can boldly advise him to stop or curtail. Of course, you can always go back to the same treatment.
All right, sir. I personally use the recent Midas score. It has been evaluated, thankfully. Midas score.
Midas, of course, you are using it.
Uh,
That's fine. That will complicate the whole presentation. I have purposely not done it. But of course, it is the same thing what I have just talked about the diary. Yeah? I suppose.
yeah, sir. It's actually it for me personally. I think it's more objective, and I can at least I have some score to say whether your headache has reduced in terms of percentage. That's the only use of that score.
That's correct. I have purposely not brought this the questionnaire because, as I told you in the beginning, that most of the my patients will not be as intelligent as Dr. Bhargav. So it is difficult to train our patients to maintain all these this diary and respond to this questionnaire.
Definitely, sir. There is another question. What is your experience with gabapentin and pregabalin? And can you please elaborate on divalproex in migraine treatment?
Divalproate, as valproic acid, is good for giving for prophylactic treatment. As I showed you, and as I have put this valproate into pyramid in the second table, and that is good for prophylaxis. And what happens if there is serial attacks of migraine, and if you have given valproic acid today, so it may not abort an acute attack, but say about after 2 or 3 days or next day, it will definitely help in reducing the chances of developing migraine. It will act more like a prevention rather than treatment. And topiramate is again very, very important drug. So you can use basically you have learned in allopathy, it is the responsibility of the physician to pick and choose a particular drug to treat his patient. Any diagnosis, there are number of diseases like antibiotics, there are number of antibiotics now. Even simply if you take anti-amoebic, you will definitely prescribe different drugs according to your patient's choice or response, which you have encountered in the past. So, make responsibility will definitely lies with the treating physician, whether he chooses to treat his patient with triptans or valproic acid. But of course, beta blockers probably is the first thing to be prescribed.
All right, sir. Uh, I think that's about the end of questions. Uh, I think we can safely close the
Yeah,
session for today. Thank you so much for giving us such a splendid lecture, sir.
thanks a lot.